Thank you very much, Grace. So now we're going to turn over to both the live and online audience for questions. I think we have about half an hour. And I know that Deborah is going to be reading out some questions.
Yes, we have quite a few questions here. Some people are answering questions as well. So I want to pick out, no, sit down. Yeah, sit down, Grace. So the first one we have is, and maybe I think this is a question for you, Karen, and it is, do OTs and SLPs have education directed towards children with ASD as compared to board-certified behavior analysts?
Good question. So in British Columbia, for children under the age of 6, we, and for all children, what we have is the Registry of Autism Service Providers list. And that registry has on it behavior analysts, behavior consultants, speech-language pathologists, occupational therapists, physiotherapists, and all of those professionals are regulated either through their own body, but they also are on that list because they have demonstrated experience and expertise in the area of autism. And so really, if families are looking for service providers for their child for autism, they should be looking to the Registry of Autism Service Providers list. However, there are many practitioners, many school-age practitioners such as speech-language pathologists, occupational therapists, who may not be on the Registry of Autism Service Providers list because they work in either the school system or they work in another public system, and so, but they also do have experience in the area of ASD. But really, I would encourage families to ask those questions. In British Columbia, autism funding is an individualized funding program, so families really are the employer. So they can quite freely ask the questions about a person's experience in the area of ASD.
Okay, the next question from Leslie is, I think one we're going to direct to Richard, and that is, what functional assessments do Bcbas use to measure function?
Which measures do we use to measure function? Well, the answer to that question is a university course in functional assessment where you learn the multitude. But essentially functional assessment is a process that may include interview, may include some direct observation, and the gold standard, so to speak, is an analog functional analysis of problem behavior. So it's kind of a funnel shape where you start with indirect assessments like an interview and you work your way down through direct observation, and the most rigorous being experimental functional analysis. And at the end of that process, you should have a reasonably firm hypothesis regarding the function or functions of problem behavior, and then proceed with a function-based treatment plan.
Tony, I think this is a question for you. How does a young adult get a diagnosis of autism or of Asperger's syndrome in British Columbia?
So usually the young person should go and talk to their GP in the first instance, and the GP might know that a local child psychiatrist or adult psychiatrist or psychologist is able to make the diagnosis. If they're not, then usually they will ring your organization and find out who is the nearest expert, and if all that fails, they come to me.
I think this is, realistically, there is a tremendous shortage at ACT. We receive a lot of calls from adults with autism and from families looking for a diagnosis for their adult child. And it's very difficult. There's a tremendous shortage in the province, which is one of the reasons why we are doing this series, because we want to bring attention to that. Now, our next question, I think maybe Pam, maybe Karen, this is another one for you. It's from Pam, and she's asking for clarification about whether autism funding can be used for mental health services. You mentioned it doesn't cover it. Can you explain this further, please?
So we have two autism funding programs in British Columbia. We have autism funding under age 6, and that provides $22,000, access to $22,000 to purchase autism intervention services. And so those services are purchased from professionals who are on the Registry of Autism Service Providers list. And so typically the professionals on the autism, on the RASP, I won't keep saying Register of Autism Service Providers, it's called the RASP. Typically those professionals are specialized in autism-specific interventions, so speech-language pathologists, occupational therapists, behavior analysts, and they're not necessarily mental health clinicians. So that's for children under the age of 6, and families who access the under 6 program need to purchase their services from someone from the Registry of Autism Service Providers list. The other program that we have in British Columbia is the autism funding ages 6 to 18, and that provides access for families $6,000 per year to purchase autism services. And some of those services can be used. If you take a look at the Autism Handbook, if you simply Google MCFD Autism Parent Handbook, there's a page there that talks about the eligible services. And those services are a little broader than they are for under age of 6. And in some of those, they can purchase therapies, other types of therapies related, but not necessarily specific to mental health. It doesn't necessarily mean that they wouldn't be able to purchase services from a mental health clinician that is providing some intervention related to their autism symptomatology. However, the majority of service providers on that list are really about autism-specific interventions.
I think that Dr. Gill had something to say about the assessment of adults with Asperger's. Kids. Okay. You wanted to speak about kids with Asperger's. Great.
Yeah, the process for diagnosing autism spectrum disorders in general is that the referral from the physician, from the family physician, really comes to usually a pediatrician, and an assessment from the pediatrician then is forwarded to Sunny Hill Hospital at the British Columbia Autism Network. They will review the file, they will triage, and they will eventually interview the child. And they use two tools for that. One is ADI, which is a schedule for interviewing the family. And the second one is ADOS, which is for observation of the child and the behaviors. So based on that, the diagnosis is made. The diagnosis, once it's made, it really then qualifies the family to receive the funding. So that is the process of diagnosis. But the things are changing right now. There are a lot of private services that are getting involved. So the families are directly accessing the private agencies to go for a diagnosis, and that's how they get the diagnosis and further funding for that condition.
So just for clarification, it's probably worth adding that these very stringent assessment tools went hand in hand with the provision of autism funding, so that people could be sure that the children who needed the services were those that were getting them. Once an individual moves into adult life, there is no requirement for any particular type of assessment, although people like David Walling and I use the ADI and the ADOS with adults as well. There is no requirement in adult psychiatry that those instruments are used, and I think one of the challenges for the future is to help adult psychiatrists and psychologists who see adults to feel much more confident about making a diagnosis in adult life, because we know that worldwide the most able individuals frequently are not diagnosed till their 20s, 30s, 40s, and I occasionally see individuals in their 50s.
So there's another, I think, a follow-up comment from Susan here, who says she works as a mental health clinician on a child and youth mental health community team. and that her colleagues are excellent in their training and approach to mental health issues for neurotypical individuals, but none had confidence in supporting an individual with ASD and mental health issues. I wondered, Tony, maybe if you could address that.
Why doesn't Grace?
Yeah, okay, Grace, sorry.
I think that the treatment itself is not that different. So, for example, at the neuropsychiatry clinic at the Children's Hospital, they use a CBT, a cognitive behavior therapy model. It was designed for children with ASD, but essentially the components are very, very similar. It does require some adaptation, and so I think that's where you might want to work with another person on the team or have some kind of consultation with someone who has more experience with children with autism. But it's not a completely different treatment. So there's a lot of overlap, there's a lot of similarities in terms of how we might treat anxiety or depression in people with ASD as compared to, what we would call neurotypical individuals who don't have ASD. So I think that it's not that huge a gap for someone who is already experienced working with typical children to then either get some additional training or to work with someone else on the team who has some experience with autism, but maybe as a behavioral consultant or a speech-language pathologist or someone else who has that other piece of the training.
So I think it's worth elaborating that there are no mental health treatments for these disorders that are specific to children with ASD. We're using the same approaches as we use with all other children. And I think what Grace is highlighting is that often the underlying issue is a lack of confidence on the part of the practitioner, because an individual practitioner may not see many children with ASD in a typical year, and therefore be anxious that somehow they're not taking quite the right approach. So I think in that sort of situation, people should feel, on the one hand, confident in their existing clinical abilities, and on the other, able to contact any of the people on this panel, or indeed other experts who are always willing to offer advice over the phone or in email about individual cases.
Indeed, there's lots of specific questions that we can answer from ACT in terms of how much funding is available and what it's available for. So the questions that are really specific to the autism funding program, we can help answer those. Here's a question, Tony, perhaps you could help decide who on the panel is going to get this one. Any suggestions for school support, as they appear to have limited resources to be consistent with support at home and the community?
I think that's one for Richard, who might also mention pop art in his...
Thank you for that prompt. It is fundamentally a policy issue that comes down to appropriate funding. There needs to be more money. Unfortunately, I don't have any magic solutions around that. This requires behavior change at a governmental level. Policy. I haven't figured out the contingencies to affect that yet. However, in the short term, or in the absence of that, the Provincial Outreach Program for Autism and Related Disorders, or POPARD, is a government-funded resource with a lot of fantastic teachers, psychologists, and behavior analysts who can be called in by a school upon their request to come in and share resources and help out teams that might be struggling.
I wonder if there's any questions here. I wonder if you could take the microphone over there, just because otherwise people in the audience won't hear you. Okay. Well, maybe we can get it down a bit. David, could you help adjust that if it's too high?
Can you hear me? Or you could bring it down.
Just bring it down a bit, yeah.
Yeah?
Yes, we can.
Okay. So I guess my question is related to what Dr. Gill was talking about having, when parents first get a diagnosis. And so there's lots of helpful services on ACT, but I think a deficit is we don't provide people with a mental health service providers list. Is that something you would see doing in the future? Or where's the mechanism to me for MCSD? I know when parents first start going through this, I have a child who has mental health and issues, NASD. It was a long time before we sort of, in his journey, before we discovered the association. It wasn't something that was given to us up front by any of the very good professionals that we were working with. So where in the cycle will we introduce that for families? You know, I know that his behavior program was helpful because we documented his behavior over years and years and could show that data, and it helped with his diagnosis. But it would have been nice to know earlier on that it was a possibility.
I think it's a great question, and I think that we have learned a lot about autism and treatments and just comorbidities and autism over the past 20, I'm going to say 20 years, but even more from the past 10 years. I'm encouraged by events like this where we have, I think, in cyberspace, we have well over 100 physicians who are watching as well today in terms of better education for folks so that, as Dr. Gill said, that when families are initially going and talking to their physician, that they are mentioning and starting to question the issue around mental health and are starting to connect families with, through Ministry of Children and Family, there's the children and youth with mental health clinicians across the province, just as there are children and youth with special needs workers across the province. And I think that with sort of things like this, I think we could do a better job as we move forward in identifying that to families from the get-go, so people are sort of more aware that that's something that they need to pay attention to. Did you want to respond as well, Dr.
Can I just add that I think there is an issue here about stigmatization. So I think children and adults with ASD still carry some whiff of stigma with them in medical circles to do with the anxiety that it generates in the clinicians that they may not have the skill set to deal with these children and therefore, or adults, and therefore they're reluctant to see them. And so I think the overarching challenge is in some way to normalise this group of children and adults so that all mental health clinicians feel confident in dealing with them, because the truth is most clinicians do already have the skills to deal with these children, and we don't want them put into little silos or ghettos. We want all clinicians to feel that this is part of their everyday work.
Now we have a question. Sorry, go ahead.
I just want to touch on this issue again, that, you know, I'm really trying to talk to the parents, and I really want to find ways to support the parents. And the parents need to know that, you know, they have a family physician who they have known for a long, long time. That person has been involved with the care of their children. That person can gather all the information. That person is an unbiased supporter of you and your child. And for that reason, having a physician know your child from the very beginning so that they have a baseline. You know, a physician who knows what's going on with your child on a 6-monthly basis. They know what your child's basic behaviors are, what is the baseline of those behaviors. Then they can tell if there's a change in that behavior. And you know, that is very helpful to know, because that's when the physician can start saying, listen, you know, this is not going in the right direction. Maybe we should start looking for some help. Maybe we want to find out if this is anxiety, or if this is OCD, or is your child getting depressed. So, you know, I think it is very important to have one person who the families know very well, to give them all the support and the advice. And then from there on, it can move forward. It can move forward to, you know, child and youth mental health teams. Have the counselors there look at the child. But when the child goes there with a diagnosis, or at least a concern about mental health from the family physician, you know, they are going to be looking at it in a more serious manner, and they are going to put a little bit more thought into what do we do next. So I think that has to be the process, and I think eventually we need to get to that process.
So one more question here from the audience.
Thank you. Thank you all for your expertise and insight. I just want to share an article from a Toronto group of scientists from the Center for Addiction and Mental Health. My current interest now is tobacco and addiction. But anyway, the study showed that there is a brain structural impairment common in ASD, ADHD, and OCD. So mainly the white matter tract, and there's more severe impairment in kids with ASD and ADHD more than OCD, and particularly the white matter is vulnerable to the growing period. That's why you see an earlier onset of ADHD and ASD in children than OCD, which occurs at a later age. So what they're seeing is it cuts across a spectrum of behavioral symptoms among these different conditions, but historically they are treated separately. So instead of looking at it in total, and also a fairly under-recognized condition, sensory processing disorder, which is so huge in the OT world, has not still made it to the DSM-5, and arguably so. So I guess any comments, any insight, what's the future of the direction with this current finding?
There's been a sizable shift in thinking about psychiatric disorders over the last 10 years, from seeing each individual disorder as tightly encapsulated, having its own set of etiological factors and own pathophysiology, to a recognition that although from the perspective of symptomatology these disorders may be very different from each other, if one looks more carefully at either genetic risk factors or brain pathology, that one sees much more overlap. So we need to be careful here about not throwing out babies and bathwater. We clearly don't want to lose the importance of symptoms and signs as being a very clear guide as to the sorts of things we should be doing to help people, but we need to be mindful that these things tend to go together much more often than we'd previously supposed. And I think the clinical implication, particularly for children with neurodevelopmental disorders, whether that's ASD, ADHD, language disorder, epilepsy with an onset in childhood, is that when one's taking a history, one really needs to cover all domains of functioning, because although we've focused for good reasons on ASD this evening, it's not uncommon for children with ADHD to show very high rates of anxiety and depression, and often they're not picked up either.
There is another question here, Tony, and I'll let you decide who gets a portion of this one. It's a very important one. Is there any research on the rate of suicide or attempted suicide in those with ASD compared to others?
Yes, there's a small amount of research which essentially shows that people with ASD are not protected from the risk of suicide. In other words, if you are depressed and have ASD or Asperger's syndrome, whether you're a teenager or an adult, you're at the same risk of suicide as someone with an equivalent level of depression who isn't. And indeed, there might be reasons for thinking you're at higher risk because you may be extremely socially isolated, particularly young adults who are no longer living at home. If their mood drops, other people may not be aware. And sometimes one sees patients who have had repetitive thinking about suicide, often from childhood or their early teen years, and this can lull people into thinking this isn't serious, this is just the child's usual stereotype speech, and not realize that actually the speech may be the same, but there's been a mood change that quite dramatically increases risk. I take it from your hovering presence that we're finished with questions.
We are, but there's a couple of more questions in the room that we, perhaps after I wind up the presentation for the people online, because I don't want you all to pull the plug on me before I finish the other important stuff, that we can stay a few minutes more if there are other questions. And for those of you who would like to email info@actcommunity.ca with any questions you have, I'll try and, to the best of my ability, find you the answers. Now I'm going to switch to this mic, give you that. My job now is to thank you all for being such a great audience, both here and online, and to remind you to complete the attendance form for CME credits, and to complete the evaluation form. And even if you are not getting continuing medical education credits, we'd love you to do this because it's very important for us to have your feedback. We're doing another webinar in a couple of weeks, and we're into continuous improvement at ACT. One question I saw was we should have a conference on this. I'd like to tell you we are having a conference. It'll be towards the end of April. It will be our April Focus on Research event. We'll be focusing on mental health and autism. Also, some of you are watching together. We would really welcome that the person who organized you sends you all this critical information so we can know who's been online today. I've included at the back of your handout and online resources that ACT has available. We've developed a page for our website on mental health resources. And we also welcome you because there's some very knowledgeable people listening and here in the room who might be able to suggest good resources to us. One of the challenges is that there isn't, there's a sort of chicken and egg thing that not much attention has been placed on this. The resources aren't strong enough, so we're very interested in finding out what's out there and sharing it, and we'll be doing that through ACT's mental health resources page on our website. We do have human beings to answer questions from parents and professionals, whether they've just had a diagnosis or they're concerned about mental health and their child. We have people who are really very well trained, and one of the first questions we ask now of parents who call us about their children is, what about anxiety? Because it's become such an issue now, and we realize that if we don't ask the question, parents often don't bring it up. So that's a very important thing that we want to bring to your attention. I won't go through all our resources except to say we've got a lot of them. We've got 18 online videos that deal with everything from sleep, toilet training, sexuality. We would really encourage you. We'll be editing this presentation along with other the next webinar, and we'll be developing online learning modules over 2017. So suggestions that you have, feedback for us will be very important. And we are always trying to find out better ways to serve you. We have a survey that was developed by the advisory committee and by with the help of UBC CPD, and we invite you all to fill it in and share it with your fellow professionals. One of the things I've already heard feedback from is that we knew nothing about this. It's very challenging to reach everyone in the we're also inundated with information, right? Emails coming at us, resources. So if you forward this information on to people that would appreciate it and maybe participate in the next one, that would be tremendous, because I think it's that kind of support for this initiative which will lift it up and beyond. So our next presentation is on November 17th, same time, same place. And I want to end by acknowledging at ACT that where we're incredibly fortunate is the support we have from professionals around the province. This initiative, the people in the advisory committee are volunteering their time. UBC CPD has done a remarkable job of keeping us on task. And we are very thankful to the professionals who are listening and would like in any way we can to support your work. Thank you.